service that they're from. Maryland has a lot more public service obligations.
Yeah,
From being.
so they haven't done.
So
That's
more
fine.
behind, yeah.
Huh.
Just a thought.
Yeah, I mean, it's maybe about like general government. Yeah, I think that's like. Yeah, that's if they want to see government capacity, like. Let's look at like population of like people, you know, in some way.
Well, yeah, it also becomes political. Like, is your, because I'm not sure that it would all. Yeah, you. Virginia's not been. But. Politically. That was exactly.
So when they decided to do something, they just do it. I could also see it going the other way, like if your government knows that you things, you love things.
Yeah.
Stuff.
And where's the bigger? Because
Yeah.
clearly not interested.
Yeah, like is there like a thing that happens? Like is there like in this one, like typically other like yeah, things.
Right.
Ish.
Exactly. Yeah.
Yeah, it really depends a lot on like, is this like an in-house or an in-house thing? Like, they just get lucky and hire. Yeah. Doesn't happen. Yeah. I buy like, is this? It's usually not, sometimes it is, a very boring part. With serious implications. I mean,
So many of these things are.
yeah. Yeah. That is interesting. Yeah, I think I mean, like. It's kind of like they're two different directions here, and I don't know.
I don't know if there is that
kind
of. You know, my sister's all. Is that what it, yeah, project type or like center of public good? There would be.
One like episode I find. Yeah. Anyways, like 10 days. Thank you.
All right, everyone. Welcome to our first colloquium of the winter quarter. This is one I've been looking forward to for quite a while. So we're very pleased to have with us today Aimee Hilado from the Crown School, where she's an assistant professor. Prior to coming to Crown, she earned a dual master's degree in social work and applied child development at Loyola and the American Institute, or PhD at Loyola as well. She's a licensed clinical social worker, and she was the founding clinical director of the Refugee One Wellness Program, mental health program she developed for refugees and immigrants at the largest refugee resettlement agency in Chicago. And we're really pleased to have Aimee be able to join us today to talk about her work in Chicago with the immigrant and refugee community. And I'm going to apologize in advance. I am teaching in a different building. I have to sneak out, but talk will go for about an hour. And Aimee, the floor is yours, and I'll get out of your way.
The kind welcome, kind introduction. Thank you all for coming out on such a cold day. Maybe you had to be here, but it is bitter out there. It's taking a little bit of time for my face to just thaw. In terms of just building on the introduction, a lot of my research is really built on the work I've done in the field over the last 18 years. I've had the privilege of being a licensed clinical social worker, a teacher, as well as a researcher that specializes in immigration trauma. I think a lot about refugee, immigrant mental health, and really thinking about culturally responsive practices. Oftentimes when I think about the work that I do, it always begins with these images. These are the images of people who will travel by land, sea, and air with no guarantee of survival, but yet they carry with them the hope that their lives can be better, that they will have an opportunity to live their lives with safety and dignity, and be able to, against all of the sacrifices they've made, that they'll have opportunities to rebuild. when I think about the work, to situate my work begins at the relative end of the immigration journey that most people take. That my work is situated on what it takes to help people adjust to life in this context. And I will say that the US has had a long history of welcoming those that are seeking refuge, seeking that opportunity to rebuild their lives. But what we know, and what many of you have likely seen, is the change in rhetoric over the last decade. That who gets to have refuge, who we see as vulnerable, who is welcomed in the United States has shifted. As we've seen more restrictive immigration policies, more anti-immigrant rhetoric in terms of who is a newcomer, who is welcomed, and who gets to receive support. So oftentimes we need to go back to why are people moving in the first place? According to the United Nations High Commission for Refugees, there are millions of people that are on the move globally. And when we think about who is coming to the United States, sometimes they are coming because of political repression, economic instability in their home countries, and the growing attraction of our labor demands here in the United States. What we also know is that folks that sometimes will come here that don't necessarily have legal standing here, we don't have strong diplomatic ties with their home countries. So there is no clear pathway for once people come here. If there is no space for them, they have no pathway to work here legally, live here legally. There is no way to repatriate back to their home countries. What we also know is that we've seen an increase in really dangerous, restrictive immigration policies that have forced folks to make decisions that are not always aligned with our current immigration systems. And so I want to highlight MPP, the Migration Protection Protocol, also known as the Remain in Mexico policies that really came about during COVID. Also the weaponization of Title 42, which was a public health policy that was again designed or used to restrict entry for folks that had a legal right to apply for asylum at the border, restricting people from actually entering the United States while awaiting their asylum hearings. Human Rights First is an international human rights organization that has been on the ground in Mexico during the time of COVID when MPP and Title 42 were applied during the pandemic. And their reports from even several years ago reported over 10,000 cases of sexual violence, physical violence, rape, kidnapping for people who were barred entry to the United States while they had pending asylum applications. And so if you are in a state, you left your home country because you have a well-founded fear of persecution, you are moving because you want to survive, you are exercising your human right to apply for asylum, and yet our systems are blocking you from entering at a port of entry, people will make the decisions to enter the United States outside of a port of entry. They will do so in ways that are much more dangerous. There's greater risk, but they do so with the driving force that they want to survive. And so that's why we've seen quite a number of overwhelming surges at the border states. And, you know, as someone who really thinks about immigration, and I think about the human rights component of immigration, I am also sympathetic to border states that are seeing tens of thousands of people that are coming in. They don't have the federal funding, the state funding, the local funding, or the infrastructure to welcome so many people that oftentimes come with very complicated health, mental health, social, emotional adjustment needs. And so in many ways, I want to hold on one side the compassion for border states that were not equipped with the resources to welcome that number of people, an immigration system that is not equipped with a number of judges and attorneys to adjudicate the cases, as well as thinking about really the well-being of arrivals that are coming because many of them feel that they have no choice if they want to survive. So how do we balance the two? What has been hard is that in the absence of comprehensive immigration reform and guidance at the federal level, states and local communities have taken greater authority and agency in thinking about how do we process new arrivals, and they have turned to more cynical ways of doing that. And we're going to talk about that today. Before we get too far, though, I do want to make note that immigration status really does matter in the United States. I think that we can take this idea of everyone as a refugee, but really, if you look at US immigration law, a refugee is not an asylum seeker, is not a parolee, is not a migrant. The statuses here in the United States really do dictate what rights and privileges are allowed When you think about a refugee is someone who, again, identified abroad, starts the application. Those folks are processed differently than those that are filing for asylum at the US border. And just as a kind of brain exercise, as the brain thaws and everyone is eating lunch, if you were to come through the US refugee program, so you are identified by the United Nations, UNHCR, you are processed by our State Department, what is the average number of years it takes from filing your application abroad to resettlement in the United States? What do you think it is? Average length of time of processing from application to resettlement? 7 years. 7 years, 3 years, 10 years. Feels like the price is right. It's actually 17 years. And so not everyone waits, but again, average. When I think about 12 years that I directed my mental health program, I was working with arrivals across 5 different global regions. Some folks waited even longer. I was supporting arrivals from Sudan who are waiting, and the Congo and Burundi that were waiting on average 22 to 23 years. Refugees, Bhutanese refugees coming from the camps in Nepal were waiting 23 years. The Rohingya Burmese that are in camps in Thailand or coming through Malaysia, 16 to 17 years. Folks that were coming from active warfare in Syria, maybe 3 to 4 years. But again, you think about what happens in those periods of time. What exposures to trauma and insecurity, these environments of deprivation that will directly influence not only physical, but psychological well-being. All of that comes to play. And so the difference is, however, if you come through the US refugee program, you may wait longer, but you have a direct pathway to citizenship. You can adjust your status with a green card in 10 months. You can apply for citizenship for 1.5 years or in 4.5 years from arrival. Already before you arrive, a refugee resettlement agency affiliated with ORR, we get your biodata form. We know who's in your family. We know exactly what you need. We're there at the airport with an interpreter to pick you up, to bring you to a fully furnished apartment where within 24 hours, you're going to come to the agency and get a host of case management services. The news outlets, when you're hearing the term migrant, they don't have a pathway to citizenship. They don't have access to an organization that's going to pick them up wherever they are, to give them the host of services. There's a lot of uncertainty. And so then we try and think, how do you strengthen communities? How do we think about integration adjustment when those experiences are fundamentally different and it is based on immigration status? So this is what I study in my lab at the U Chicago Crown School, that I am very interested in wondering what interventions, what programs work for who and when and under what circumstances. How do we think about intervention and programming that support emotional, mental health wellness for the person, for the individuals, these newcomers, but also the workforce that is supporting them? Because trauma work is not easy work. Secondary traumatic stress, burnout are quite real. And so how do we sustain workforces to ensure that we're doing this work in welcoming new arrivals so that they can be part of a larger, stronger community? And so as part of the flavor of the work, I will say that trauma is something that seems to be a through line, a common denominator of many of the experiences for people that move to survive. So I just want to take a brief moment to talk about what trauma is. Trauma is a threat to your emotional, psychological, physical well-being, to yourself or people near you. It's experienced as something that is overwhelming. It comes with intense feelings of fear and lack of control. So if you're afraid and you don't feel you are an agent in your environment, it can leave you feeling hopeless. Depending on the age that you experience the trauma, how chronic it is, the severity of that trauma, it can actually change your perception of yourself, the people around you who you can trust, and even how you vision for yourself, thinking about what will my future look like. And over my years of practice, I will say that again, irrespective of country of origin, there are just common symptoms we see of mental distress and trauma that are universal for adults. I realize that I put that picture. Let's go back here, right? Oftentimes, folks that have experienced these sustained moments, experiences, periods of trauma and distress, they tend to have changes in appetite, mood, sleep. They will talk about their symptoms in terms of somatic symptoms, so physical manifestations of mental distress, the chronic headaches, the back pains, the flashbacks, the hypervigilance. In young children and youth, we know that children and youth develop in the context of helping and thoughtful and nurturing relationships. And children and youth will struggle in the absence of being surrounded by adults who can model how to cope, who can model how to problem solve, who can model how to tune in and communicate. And so with children and youth, we oftentimes will see similar behaviors, similar symptoms. So acting out behaviors, withdrawn behaviors, complaints of stomach aches or headaches when they are nervous, being socially withdrawn. And I've even seen mental health problems in infants and toddlers. Again, development happens in the context of relationships. So outside of typical normative child development, these are the kids that are these babies that are so difficult to soothe, excessive tempers, even regressive behaviors. When I think about the work I do in shelters, I will have, 3-year-olds, 4-year-olds, where parents will say, my kid was potty trained, but over the course of the journey, they've lost that skill. These are all manifestations of trauma that we also weave in the realities of intergenerational, historical, and cultural trauma. I mentioned to you that some of these folks that are displaced, they're living decades in periods of uncertainty and unsafety. And that then passes from generation to generation. The way that people cope, the way that people relate to one another, that is then seen across generations, over time, and across communities. And so there are certain things that I care about, that I understand, that I seek to study, that I understand, and things that intersect with the work that I'm doing in Chicago with the migrant arrivals. There are things that we know when it comes to trauma. We know that it has a cumulative effect. So it's not just trauma experienced in home country, it's trauma that it's experienced in home country, plus experiences in transit and experiences post-resettlement. That if you come to this country and you realize, my gosh, I have shaky legal status, I'm not welcomed here, housing insecurity, food insecurity, those compounded effects will have a cumulative impact on the mental health of the people we work with. We also know that if we don't address it, it will actually be more difficult to adjust. Integration is harder. Being able to understand systems, navigate a novel environment becomes more difficult. What we know about new arrivals is they're most likely not going to come and ask for mental health services because we know stigma is real. We know that there are cultural understandings of mental health problems that sometimes it is we think about culpability. You're sick because you did something. It's a product of your own moral failing. Right? You shouldn't be asking for resources. And sometimes the reality of there are other priorities I need to pay attention to, that I can't worry about my mental health problems, nor the struggles of my children, because I'm worried about making sure I get a job, making sure I can be here. What we also know is that in the current socio-political climate where we are villainizing newcomers, we are using language that feels really unsafe, that it is really hard for people to ask for help. They will not go to providers, they will not go to institutions unless they are known. And I think the rhetoric around mass deportations and Chicago being ground zero for that post the inauguration is actually leaving a chilling effect across all communities, irrespective of status. So folks that do have a pathway to citizenship, like refugees, they're already asking, are we going to get deported as well? Can we be rounded up? And so that changes behaviors, not just help-seeking behaviors, but just how we function in schools and how we function in the workplace. Which now brings me to Operation Lone Star busing program. The first buses that Governor Greg Abbott sent to Chicago began in August of 2022. It is wild to me that we are already 2 years into this, going on to 3 years. And granted, we have not seen a bus in the last 6 months, but that has not changed. I will say, yes, it has slowed down, but not only did the busing program really impact the landscape of what we saw in Chicago and our collar counties, it influenced folks that were coming to Chicago by other means, so not just through the busing program. And there was great diversity in who was arriving and how continued to arrive, even though the buses and the migration patterns have slowed. But this is a map, whenever you see kind of the star, these are from the city briefings from the mayor's office. And if you are interested in those briefings through the new department, Division of Immigrant, Migrant, and Refugee Communities from IMMR. They used to do bi-weekly briefings. Now we're at monthly briefings, but this is publicly available information that is available through the City of Chicago Mayor's Office. I think that there was a lot of dialogue around, oh, it's the Venezuelans, this is the primary group. And yes, I would say at any given time, 70 to 80% of the arrivals were coming from Venezuela, but there is quite a bit of diversity as well that we want to make sure that I want. Now, when I think about Operation Lone Star busing program, it was really framed as an intentional by design to disrupt and to create chaos in the absence of a federal response to immigration. And again, I go back to how do we hold compassion to border states that were not equipped, but also recognizing these are human lives that were being moved without any information. It was chaos by design because there was no communication between the Texas administrations and Chicago. We never knew what buses were coming, how many buses, how many people were on those buses, were there any medical needs? And so if you even look at the numbers, Chicago, these are old numbers. Chicago at this point has received over 52,000 arrivals. Not all of them came through the busing program, but that's a huge number, but not as large as other states. And through this work of being part of the response, I've spoken with leaders from different states, not even the ones mentioned here, who are also receiving migrant arrivals. Each state has responded differently, but again, I think every state, even though the response has been different, everyone has the same sentiment. It was designed to create confusion. It was designed to create harm. It was designed, to really strain local resources and to even divide communities. And we saw that happen directly in Chicago. There were a lot of questions on why are we getting involved? So the new arrivals mission, now I've seen this response go through two administrations. So under Mayor Lightfoot, migrant reception plan, new arrivals project, to now under Mayor Johnson, just a shift in how we think about framing of the response. Is it a crisis? Is it a response? Is it a project? And I think the language, the words that we use actually influence how people understand who is responsible, who should be helping, which sectors should be engaged. I won't go too deep into that part of it, but I want to pin that. We have to get curious because the words we use certainly have framed the outgrowth, the ripple effect of what the response has been. Over 50,000 asylum-seeking migrants have arrived here. The city of Chicago actually created a resettlement model to welcome them. It was designed to meet basic needs. And then ultimately, the lessons learned from that was how do we now build an infrastructure for anyone that is experiencing homelessness who need wraparound services. But before I get too far in terms of the new arrivals mission, let's look at the numbers. Again, the headlines were telling, there was a time in which we were getting 15 buses at a time, 15 buses a day, every day for weeks. And when you're thinking about, again, as a city, we were not equipped to welcome those surges of numbers. I don't think any state, any city was. When you think about who is arriving and you think about patterns of migration, historically it has been people come to reunite with family or they come to a community that is established. And oftentimes it is the family or that community that will help with those basic needs. Live with me. I will get your kids enrolled in school. I will get you connected to the health resources. But what we saw with the Operation Lone Star busing program, these are folks that had no ties to Chicago. There was no strong ethnic community that was ready to welcome them, and certainly not at the numbers that we saw. And so these surges really tested the system of what a welcoming reception plan can look like. This circle was the coordinated strategy that really had not shifted from the time the first buses arrived in August of 2022. That there was a priority in standing up large, congregate facilities for housing, expanding staffing, and I know a lot of controversy around contract staffing from other states, favorite staffing in particular, while blending community-based staff to help with that local, that local knowledge that was needed. For the first time and very rapidly, we had to align city, state, local municipalities because there was no federal funding for this. The city, the state had adjusted, had reused some of our FEMA dollars, but it really was insignificant. It was a drop in the bucket to what was really needed to house the tens of thousands of people. Working with aldermen, pulling from foundation support, advocating and working with faith-based communities. This was a time where if you were interested in kind of the grassroots organization of this, I welcome you to Google search the Welcome to Illinois Coalition. That actually was born out of this response because city, state, we were figuring out how to communicate to one another, and organizations said, how do we leverage what we can do in communities? And they grew. This Welcome to Illinois Coalition was just community orgs that said, we do legal, we do X, Y, and Z. How can we be part of the response? They were blocked from a lot of the engagement under the Lightfoot administration, but the doors changed, the kind of the flavor of the work changed with Mayor Johnson, a lot more coordination. While that's happening, focus on federal advocacy because we needed a response. And this is the priority, top 4 priorities. Mental health came later on down the line, and in part because there was just increasing observations of mental distress. And we did lose one migrant arrival to suicide. That person was living in a shelter. And that really became the ripple effect of now we need to include mental health. Even with a coordinated strategy like this, and this is unlike what you would have seen in the response in Denver and New York and DC for comparison, it still was tested. And so if you remember, there was a time when there was a measles outbreak, right? That when you have congregate facilities, high capacity, some of these shelters had thousands, if not 11 to 1,200 people at any given time, communicable diseases are going to spread. And yet the city responded, right? I'm just giving you a snapshot of one moment in time when the outbreak happened in 2024, and they were tracking it. We were moving folks to different shelters for isolation and the like. And very quickly, within, I would say in the span of a month, the number of vaccinations that were distributed, the containment that happened. And so then this cycle continued. Buses continued to arrive. The system became more refined. But at the end of the day, mental health was really front and center. We continue to see the growing distress. Remember, if you come to this state, you come to this country and you realize you are not authorized to work. You don't have a pathway to citizenship. Housing vouchers have dried up. That shakes your sense of safety, which is a fundamental human need. We need to feel safe. We need to feel stable. And mental distress started to increase. So this is where my colleagues from the Coalition for Immigrant Mental Health, this is a nonprofit organization that is a volunteer group of researchers, advocates, and practitioners who we are used to training a workforce in mental health. We are used to coordinating resources. The coalition plus colleagues at Lurie Children's Hospital and myself at East Chicago Crown, we were asked to be part of this response. And I remember when city state leaders, they brought us to the table. They said, could you just train more therapists who could volunteer? Free mental health, right? Because apparently we have just an overabundance of that in our world. And we know, again, I keep reminding folks, we're still in a mental health pandemic as well. We know that we don't have enough. And so we'd asked city and state leaders, can we go into these shelters? And very quickly, we realized there is no way that putting one mental health provider was going to make a dent in reducing mental distress. If your goal is to reduce suicidality, putting one stranger in a congregate care facility was certainly not going to be the solution. And I mean, I'm a therapist. I've done therapy across the lifespan for decades, and I will be the first to say, I don't think individual therapy is the most culturally responsive way to respond to distress, particularly for this arriving group. And so we did have to do a bit of re-education, really move leadership away from this idea that the only mental health care that's out there, the solutions, is staffing folks with more therapists. We needed to be able to highlight that there is a shortage of mental health providers that are bicultural and bilingual to do this, that we have to move again away from individual treatment. And how do we leverage a non-clinical community health workforce to do this work? And we proposed, let us create a curriculum that is going to focus on universal intervention strategies. So how do we make sure that everyone that arrives has access to the information they need to care for themselves? And then a stepped up stage that we will also train frontline non-clinical providers to facilitate small group connections. Because what we know about trauma is that it diminishes your sense of connection to others. It makes you forget your sense of agency. You forget how to cope adaptively, and we need to give you information how to adjust to life here. And so that's what we proposed, right? Rather than thinking we need specialized mental health care, let's use task shifting models that have been used across the globe peer support models that ensure that we use people in the community that are culturally aligned to the communities that are arriving here, and let's help them be part of this mental health care solution. And when you do that, you have these universal prevention, health promotion strategies. When you facilitate small group connections, what you're ultimately doing is narrowing the total number of people that need acute specialized care with therapy, inpatient, outpatient psych services, because we know that's inadequate. We called our intervention, our program, the Reimagining Mental Health Supports for Migrant Arrivals. The curriculum is designed and delivered in Spanish only. We actually are training more cohorts. You'll learn more about that shortly. And we're studying just the implementation science of it. Under what conditions do people accept the curriculum, implement the curriculum? What are we learning by virtue of interviewing the frontline providers through focus groups and interviews? What are we learning about the workforce that is doing this work? What are they telling us about the arrivals themselves? That is oftentimes hard to capture when you've got a humanitarian response that is moving so quickly. So rather than me talking you through it, I'm going to show you a video about it. Hi, tell me what to do to show the video. So this is an initiative, and it started, we began doing these trainings first. So it's a 6-hour curriculum. It's delivered by Spanish-speaking, non-clinical frontline providers. And I give you this very, very busy slide to just track. For me, it was tracking the evolution of the response that we began. So far, we have 7 cohorts. Cohort 8 will be trained in February at the Crown School. Cohort 9 is going to be trained in March at the Crown School. And then we will think through kind of what is to come. But even in this snapshot, we trained 695 frontline providers to be part of this mental health care solution, that it shows the changes in what the reception plan has looked like. So there was a time when we were just training shelter staff. And then there was a time in which we were then training volunteers who were in police precincts when the police precincts were serving as landing zones. We've seen just the rapid increase of high capacity shelters and then the rapid decompression, going as high as 24 shelters, staffing those shelters, and then now having only 5 migrant serving shelters. And that's where we're landing right now. And so it speaks to how a city, how a state has to flex to these changing arrival patterns. There's a larger story behind these numbers, the funding that needed to be blended, and not just, how to operationalize a response like this to welcome arrivals, but the impact it had on communities. If you were tracking some of the narratives, there was a lot of divide in communities that felt we were disinvested in, and now you took away our public school, and now you want to adjust that school, reposition that school, reframe that school, do all of these things to the infrastructure for housing when you took that away from our community. And that is something that the city continues to grapple with. The Black and brown divide, a lot of the, are these folks welcomed? Why is the red carpet being rolled out? This is language that we have heard in community forums. Why don't we care for our communities versus all the resources that have been there, given to this migrant response? It has really pushed the city and the state to think about equity in ways that we are starting to see that roll out in new programming, which I'm going to cover now. So when we think about the new arrivals mission, when we think about the peak of the numbers, just the ebb and flow, 15,000 people were in shelters at one given time, thousands of vaccines. We've had over 20,000 children enrolled in CPS. So if you are interested in education, think about that adjustment process. Children who have never been in schools. We had a lot of reports of schools not feeling equipped to navigate some of the needs that are presented in children. Some of them are mental health needs, academic needs, behavioral needs. And again, from the front line, part of our model is not just delivering the training, but we have a mini army of licensed mental health providers who then staff the shelters of where these trainees are working. Because we understand that single standalone trainings are never helpful with implementation. We make sure that our licensed mental providers are on site, mental health providers are on site twice a month, doing groups with trainees, problem solving, helping to model how to implement our curriculum. And what we're hearing from them is families, children talking to them about I'm being bullied in school. I need more guidance on how to manage my stress so I can go out and find work. How do I have healthy relationships with my partners, with my children, because it feels so overwhelming. And so that too is part of what we're seeing. Children entering schools, coming back saying, I don't want to go to school. Right? We know that folks have transitioned out of the shelter network. Some of them come back to the landing zone. Some of them are using housing vouchers. Some of them are able to secure housing. But we've also seen the building, not just of folks reliant on housing through the city, but now organic developments of housing opportunities through churches and community organizations that are starting to serve as a step down housing opportunity for those that leave the shelters. And a lot of applications for temporary protected status. Again, as we think about the executive orders that are going to come out of the next administration, a lot of questions around, will TPS be protected? What will safe spaces look like? Where will ICE be allowed? A lot of that is part of our dialogue in terms of the new arrivals mission coming to a close and what is to come next. The new arrivals mission ended effectively on December 31st. So the city is no longer using funding under this project name, project title. It is now transitioned to the One System initiative. How many of you have heard about One System? That's new, and it was launched January 1st. I was part of the work group that was supporting workforce development, but the One System initiative was to consolidate all of the available public housing, emergency housing under one roof. That no longer are we going to have a program just for the chronically unhoused or survivors of domestic violence, and then keep the new arrivals housing program separate. Now it's combined under one roof. And it's more limited beds. So remember at our peak, we had 15,000 beds. We're now down to 6,800 beds, which remains inadequate, but it's what we have now. And the hope is with continued advocacy and funding, we will increase the number of beds for this entire group of folks that are, housing insecurity is a big thing. We have learned the importance of case management, medical screening, and all of the legal supports that really the wraparound services, mental health care that is critical for helping people to have strong footing and a foundation to move forward. That is going to be integrated into this new One System initiative. And it's in place now, right? So there is a comprehensive 5-year plan to increase funding for the One System initiative. Again, there are programs that are unhappy with this. There are concerns about the safety for new arrivals in terms of what is accessible to them, what's not. How do we ensure that everyone has access to this one system? One advantage, one strength of the system is there is a unified system to track who needs housing. So we are not having multiple agencies trying to control that information. There is one central place where we can know these are the folks that are coming for housing and where we can send them throughout the city. You can imagine that it can be very disruptive for families though. Even though this system is supposed to be more centralized, if you get moved to a different shelter and you have children, that changes their school. We have not figured out a solution with CPS in terms of a busing program or voucher program, so kids can stay in their medical home or families can stay in their medical home or their school. But this is, again, we are learning by doing this, and we are into January and this system is in place. There are 5 shelters that are dedicated to new arrivals and will remain so. That's publicly available information. Those will stay in operation, and those are family shelters. The rest of the beds are legacy beds that are part of the other housing program that had historically been put in place. What's tough about that is if you are a single individual that came as a new arrival, you would be competing for beds with others that are throughout the city who are experiencing homelessness. This is the landscape of where our world is now. I think about just the lessons we've learned so rapidly. I'm still trying to catch my breath in looking at all the data that we've received from our own initiative. Again, trying to understand what conditions really supported the workforce in being part of this mental health care solution. What are the stories we're hearing from the workforce? What are the stories we're hearing about migrants themselves as they navigate really new territory as they come here, and really listening to how communities are responding to how the city and state responded in this moment. What does it mean to be a sanctuary city? What does it mean to be a sanctuary state? What are the policies that are going to be an outgrowth of that as we think about the next year, 2 years, 5 years? And how do we create equitable systems for everyone? The hope is that everyone has access to healthcare, education, the support systems that we know are important for people to thrive. And so as I think about what are the final active ingredients I want to think through, as we think about social care and building healthy communities, we will always need organizations to be part of the solutions. We will always need multi-sector, multi-agency collaboration as we try and address many of the social problems we see in our communities today. No matter what, especially when I think about the mental health of our communities, we can't ignore that that's important. It comes out in additional costs when we don't care about the mental wellness of our communities. So how do we build a competent clinical and non-clinical workforce to be part of that solution, knowing that we don't have a lot of acute services, nor are they the most appropriate? How do we create safe and welcoming communities? And ultimately, what are the areas of advocacy that we still need to think about? When the migrant response thought a lot about advocacy in the immigration policy space, in the healthcare space, there's so many more inequities that this response has highlighted. And so there's a lot of room to hold our legislators accountable to how do we create a system for all. That's it. This is me. I'd like to open the floor with the remaining time we have for questions, and I'm happy to stay a little bit past that 1:30 mark to continue the conversation with those who are interested.
So you said you're in the process of training a new cohort of community-oriented non-licensed or non-clinical workers, sorry. Under the one system initiative, since everyone's under one roof, will the benefits of that system spill over into new arrival populations?
It's a really good question. So we've always been trying to create access, increase access. And I will say the Reimagining Mental Health Supports curriculum has only been delivered to date in person. We find that that's where a lot of the integration works, but we also know that is limiting. So before I answer your question, I will also say we've adapted a portion of the curriculum that focuses on universal health prevention strategies to an online platform in English and Spanish. We have disseminated that across the country because we're not the only city and state welcoming arrivals, and that's at no cost. And it lives at the Lurie Hub. So for those of you who are interested, happy to share that. When the One System initiative came through, we then were approached by IDHS to think about, could any of this content be adapted? Because what we know is within the chronically unhoused communities, trauma is absolutely relevant in those spaces too. And so that's actually part of a readjustment. We were going to train 10 cohorts, but we said, rather than train 10, can we train 9 cohorts as part of the new arrivals mission that has effectively wound down, but we do still have 5 shelters dedicated to new arrivals and use the remaining funds to start building the scoping activities we would need to adapt our curriculum. So we will be going into other shelters, homeless shelters, and really understanding and learning and interviewing, getting a sense of what are the unique needs of those communities? Is there any content that crosses over? And then can we bring experts in homelessness that can augment what we're doing so that it stays consistent, and then we roll it out as part of the One System initiative. Trauma shows up in so many other forms. I know I've been asked, what about community violence? What about, overdoses? Can we use this content in those spaces? I pin that as an area of potential growth for an intervention like this, but just know that a lot of asks. We've seen the benefits of this curriculum. We've seen the data showing an increase of knowledge and confidence in being able to respond to mental health crises. We would love to extend it to other communities that need it as well. Please.
I understand that this is a specific initiative.
Yes.
However, as a social worker, is it possible to have this program? Well, I think it's kind of the same question, but maybe I can.
Yeah.
To have just the way this was put together for the crisis that came with the refugees coming.
Mm-hmm.
Well, we know that the content can be can be adapted, but should have always been part of our society.
I would have hoped so.
It's true. So is it like, are you the person to ask about that, or are you specifically working with? Is this the only thing you do, or are you a social worker that could make a program such as that as this was done for the.
So already we've adapted, it's, whenever you create curriculum like this, you always want to make sure that it matches whatever the population. It's very hard to just say, okay, it worked here, could it try here? We have to understand the nuance of every unique community, but already we're doing that. So I didn't mention this, but the migrant arrivals, that's one kind of group of folks that we've been working with, and that's the 695 frontline staff. We've now since piloted it with the 15 refugee resettlement organizations who welcome newcomers, refugees that come through the U.S. refugee program. And then as an extension to this conversation, we are exploring what it could look like to adapt to homeless populations. So as a social worker, I feel I am wired to want to get this out to any community that wants it.
We know this is our community.
Yes.
So we've been here for.
Agreed. I think the only limit is what's the bandwidth for our training team? How do we train the trainers to be able to do this? It's how do we make sure that we can train it in the language and the culture that is available? And I think that's where we've gotten really creative with seeking out private foundations with, if you won't fund this portion of it, can we find a private foundation that would allow us to extend the learnings? Because my colleagues and I are not ones to want to just keep this. We're not going to gatekeep this. This is why we created free online platforms, different ways to increase access. And so if there is an interest, I'm happy to have that conversation. And if anything, there is always going to be a priority to study the effects of it. Again, just getting curious about under what conditions this works and what doesn't, when it doesn't, and then how do we make modifications to ensure we are being as thoughtful and useful to the communities as we can be. Please.
It's the cohorts that for 8. But you said you were very specific in saying they're all Spanish speaking in the language. But if I recall, the map showed us
The diversity.
number 3
Yes.
or 4, right? And then we had a number coming from West Africa. Is there a language, an effort to now try this in Creole or try this in other languages so that we are extending? Because that does feed into some of those conversations, those difficult conversations we're having in the front end, which is, again, the most melanated in our country tend to get pushed to the bottom. And so doing whatever we can to make sure, even in new arrivals, we are making sure that there's parity or some type of equity, I think could go a long way.
Agreed. We've had these conversations with the IDHS in terms of, can we set aside budget to be able to train native speakers in this curriculum, and the money to be able to translate all of our documents into that language. We've talked about how do we leverage technology in these spaces to make it accessible, even in the absence of the training. So like I mentioned, we have a free course, but it's only in English and Spanish. So we've put direct asks to our funders, both our public and private funders, can you invest in this? Because it is so critical. And I think about its adaptations to the refugee community. We have Pashto, Dari, Rohingya speakers. We've got a lot of Arabic speakers who this is most effective. Part of the reason why we were so intentional of designing curriculum in Spanish and delivering only in Spanish is that we did not want the additional psychological work of figuring out how to translate. So in our trainings, we make them practice in Spanish so that they know exactly how to deliver the content without having to do the mental, the cartwheels to be able to do that. And that is so critical for implementation. So that ask has directly been put forward. We say, to be culturally responsive, it needs to be in home language. We also have to account to people's access to education. We have to, account for people's literacy rates. Folks say make a handout. Not all folks can read in their home language. And so how do we fill that gap as well? This is all part of the conversation. Good questions.
I just make one statement.
Please.
It's so offensive and I feel so disrespected.
Can you tell me more about that?
Effort that was put in to welcoming other people. It's so
Disrespectful too.
and I just, to me, just have to say it.
I'd like to explore that, maybe outside of this context, but is it
I just
because,
wanted everyone to
Of
understand
course.
that I'm-
Is it because the resources were allocated for this group?
Because I and many, and so many people that I see every day have been struggling in this country forever and paying taxes.
Absolutely.
And the idea of writing grants for and getting private and having to look for private dollars here
To do this work?
to just recognize my humanity and respond to it. To have to even have this conversation.
I totally understand where you're coming from. I think in this conversation, though, it's about the work and the research that has been done there, and that's a completely different audience about the work that needs to get done culturally across everyone
across
and in our
communities.
government structure to bring about that equity. I understand.
But it's one of those things where we saw that, when we saw the anger of communities that came up with, why are these migrant shelters being erected in my community? I absolutely agree. There was reason. There is clear reason why people should be angry that so many resources were dedicated to this. And it's how do you hold that? We have to respond to this moment because these folks are arriving, but we can't ignore the communities and we can no longer excuse that folks say, well, we didn't have money. No, you were able to do this for the migrant arrivals. Why couldn't we do this for historically disinvested communities? We have always known that. When I say, communities, those of us that do this type of social work practice, we know that there is a hierarchy on who gets what. And now a response like this has clearly shown that you no longer can make excuses as a city or state, because we have seen how you can move mountains for a response. And this is to a certain degree the rationale why we have the One System initiative. It was a direct challenge of how do you increase equity around housing when we know you did it for one group? Is it perfect? Absolutely not. Does work and repair need to happen in disinvested communities? Absolutely. And I think that's where we've got to keep the dialogue, like feel the anger, feel the disappointment, feel the rage, because it's absolutely appropriate. And then channel that into action of what needs to happen. How do we hold folks accountable? How do we talk about the research, providing the evidence that this actually works and now everyone should have it? And that's kind of where we are. We're going to capture the story, figuring out, again, what conditions where this can be applied, and then leverage that to create more equity in communities that should have had this from the very beginning. So I appreciate you saying that you're offended. You should be. Like it was really, it's painful to watch communities say, what about us? And you have no excuse. There is no explanation. We can't ignore it further. Something like this really pushed, we saw it, but now everyone sees it. And so if anything, I feel like, can we leverage this? If we now know that a city can respond and a state can respond, how do we ensure that that folds over to communities that have not had that opportunity?
Well, I think we're just about at 1:30.
Okay.
Aimee said she would stay around to further the conversation if you would like to, but.
Thank you all for being here on a very cold day.
Announcement, separate.